Good morning, and thank you for joining us for our latest Ontario Medical Association briefing on important healthcare issues in the news. My name is Dr. Andrew Park, and I'm the president of the OMA, which represents more than 43,000 doctors across the province. Today, we are out with a warning that family physicians are increasingly considering leaving their practices due to systemic challenges. We will hear from physicians about why this is happening and what solutions are needed. As part of our panel, two family physicians will share firsthand accounts about making the difficult decision to leave full-time family medicine practices because of unsustainable pressures. Both are now working in other parts of medicine. We will also discuss urgently needed solutions and the impact that a lack of family doctors is having on the healthcare system overall. Far too many Ontarians, a staggering 2.3 million people, are already without a family doctor, and that number is expected to nearly double in only 2 years. The OMA recently asked family physicians who might be considering changing practice model a very simple question. What is the one thing you want the public to know? There were two major themes that emerged: financial pressures due to funding not keeping up with inflation, and the burden of administrative work. I want to read some excerpts of what we have heard. One family doctor said, quote, "Increasing inflation makes it impossible to maintain my clinic," end quote. Another said, quote, "The administrative burden is crushing me. I am so tired of spending hours every day doing paperwork," end quote. These sentiments were echoed over and over by family doctors across the province. With every role, there are administrative duties, which are reasonable. We are not talking about completing patient charts. Rather, what we're talking about are lengthy and repetitive insurance forms and bureaucratic and unnecessarily long forms that have to be completed by a doctor. No one went to medical school to fill out forms. We want to care for patients, but the administrative work that has crept into medicine makes it feel less about caring for people and more about paperwork. It's ridiculous and it has to change. This much is clear. We need to act now to ensure there's a future for family medicine in Ontario. Data is showing us that the proportion of Ontario family physicians practicing comprehensive family medicine is declining. A survey by the Ontario College of Family Physicians found that 2/3 of its members plan to change their practice model, reduce hours, or retire in the next 5 years. And the number of medical school graduates choosing family medicine is the lowest it's been in 15 years, according to the Canadian Residency Matching Service. So, what does this mean for patients? It means that there will be fewer family doctors practicing family medicine, which means less access to care and worse health outcomes. Family doctors are the foundation of the healthcare system and are the vital link to specialist care. They help patients stay healthy, prevent disease by identifying risk factors, managing chronic disease, and get patients access to diagnostics and many other healthcare services. The result of the family doctor shortage is that all of our health is at stake. Evidence shows that fewer family physicians in our communities is associated with poor quality of life and shorter life expectancy. I'd now like to introduce my physician colleagues. Dr. David Barber is a chair of the OMA section of General and Family Practice and a family doctor in Kingston. Dr. Natalie Leahy is a family physician and is now practicing as a general practitioner in oncology with the Durham Regional Cancer Centre. And Dr. Dannica Switzer is a rural generalist in Northern Ontario. I'd now like to hand things over to Dr. Barber, who will talk about the pressures of practicing family medicine in Ontario and what solutions are needed. Dr. Barber, can you expand more on the challenges currently facing family doctors, and how can the system be improved to make practicing family medicine more sustainable?
Great. Thanks, Dr. Park. Certainly, the pressures on family medicine are many, and they're really compounding each other as well, which just is making everything worse on the ground for family doctors. The three things that I would point out are paperwork, the financial piece, and then just a burnout. To start with the paperwork, that paperwork is taking up 20 hours of a family doctor's work week. That's more than 2 days of full-time work just doing paperwork. And the paperwork is it's mostly, insurance forms and requests for certain drugs, sick notes, and it gets worse, and it continues to get worse, and it's taking up more of our time. And the reality is that family doctors didn't go into medicine to do paperwork. We want to see patients. We want to help our patients, and that certainly takes away from it. The second piece would be financial. I mean, the reality is that family doctors are business people, and right now they're in a failing or failed business model. Over the last 20 years, there's been a 20% cut in the funding that goes to a family doctor to run that business. And when doctors see this and look at the numbers, they just that's why they're looking to get out. The third one would be burnout, and I think just general demoralization. Family doctors are having to work harder. The patients are more complex these days. And as I said before, things are just compounding. I think, one of the things around the demoralization is that I don't think that the government really hasn't sent any signals to these family doctors on the ground that they know what's happening. Some of the recent announcements have been for news spots, but the crisis really needs to be solved by the doctors we already have. That's where the focus needs to be. And when doctors aren't hearing from the government, that they've got their backs, then the family doctors just, they're just giving up, and that's why we're seeing so many leaving. There are solutions, and I would point out that the solutions they need to be brought forward and worked on by government with family doctors, not in isolation on either side. And so we're keen to work and find these solutions, and they do exist. We talk about team-based care. The reality is that family doctors need people working around them, and they need those people to help remove the administrative burden and see these more complex patients. And so the government needs to work out that. The other thing I would say would just be some type of stabilization funding for doctors on the ground. When you're in a failed business model, they need to see that, otherwise they're going to keep leaving. So we have a lot of solutions. We want to work with the government on it, but as it stands, the direction we're heading and the number of patients are going to lose family doctors is just untenable. Thanks very much.
Thank you, Dr. Barber. Now I'd like to hand things over to Dr. Natalie Leahy, who will tell us about the difficult decision she made to close her family practice in Oshawa in September. Dr. Leahy, what reasons contributed to this decision, and what more needs to be done to retain physicians to continue to work in family medicine?
Thanks, Dr. Park. So thanks everybody for listening to me today. My name is Natalie Leahy. I went to medical school at McMaster and completed my residency training in Toronto at Sunnybrook and Women's College Hospitals. I finished my training in 2006. My husband and I decided to move to Whitby shortly after that to raise our family, and I opened my practice in Oshawa in 2007. At that time, Oshawa was considered an underserviced area. When I closed my practice in September, I had just under 1,200 patients. I had many patients that had been with me since the beginning. I had some two-generation, even some three-generation families in my practice. And it was a big decision for me to close. And I can tell you there were a lot of tears shared amongst my patients and myself in those months leading up to my final day, as I was saying goodbye to people that I had cared for many years. My reasons for leaving were essentially similar to what Dr. Barber had alluded to earlier. The first thing certainly is the economics of it. Right now in Ontario, family medicine is a failed business model. Our ability to bill OHIP has not kept up, like the amount we're able to bill has not kept up near inflation the last 10 years. Certainly in the last decade, I've seen billings capped, I've seen them cut, I've seen them at most increase by 1% a year. And, certainly since COVID, my expenses had reached, with inflation, upwards of 10% a year increase, and my income was not keeping up with that. And as a small business owner, I have to pay my overhead and my expenses and my staff before I pay myself. and the numbers just were not adding up. I had even gone to the point of taking on an extra job 8 years ago. I've been working once a week, doing on-call work in a hospital overnight to try to make ends meet, and even that was not sufficient. Certainly over the years, if I've had to take time off for mat leave, or when I had to get my knee reconstructed and to take some time off, or even vacation, I'm still responsible for those expenses, even when I'm not bringing in any income. I worked as a preceptor with Queen's University for a decade. So I had family medicine residents rotating through my clinic, teaching them, mentoring them. And initially, a couple of them did end up joining our clinic and starting practices. But over the last 6-7 years, I noticed a trend where my residents, when they were finished, were not choosing to set up practice. And these are young, smart, motivated people, but they were coming with significant debt from their schooling, and they just couldn't, it didn't make sense for them to set up practice when they knew that it would be a failed model from the beginning, economically speaking. So that was difficult for me to witness over the last few years. The second reason, which Dr. Barber had alluded to as well, was the administrative burden and the lack of support in dealing with that. Certainly, by the time I left practice, I was spending on average 3 hours a day on paperwork. And I'm not talking about patient charting. I'm talking about forms and prescription renewals and referrals, and the volume and requests for that type of information has just been exponentially increasing in the last few years. Like for an example, the CRA disability tax credit form went from a 6-page form to a 16-page form in the last couple of years. With the advent of electronic medical records, on the one hand, they've been very helpful. On the other hand, it's increased the volume of information coming into my inbox on a daily basis. Whereas before I would get maybe 30, 40 messages to review a day, by the time I left, I was getting on average 100. And that wasn't directly related to patient care. That was just FYI information that I was having to kind of sift through. And then we don't have a centralized referral system in this province for referring to specialists. And I was spending an inordinate amount of time trying to become the patient navigator and figure out which specialists were taking on new patients. And it was not unusual for me to have to try 3 or 4 different specialists, multiple referrals before I found someone that would see my patient for a specialty need. So that was also taking up a lot of time. And as Dr. Barber mentioned, I had actually had to reduce my clinical hours in order to accommodate all of the administrative tasks that I was dealing with. And I liked working with my patients. That's what I enjoyed. I enjoyed the clinical work, and the administrative tasks led to sort of the third issue, which led to me leaving, which was burnout. I had experienced a fairly significant episode of burnout in 2014, and I had put measures in place to kind of protect myself going forward, some better self-care, more boundaries at work, etc. And then COVID happened, and all of a sudden I was faced with an unprecedented pandemic, as we all were. I remained on the front line, seeing patients in person, in urgent care. I worked at the COVID assessment centers, the COVID vaccine clinics. I was putting in a lot of work to help out during this scary and uncertain time. And during the course of the pandemic, I also was dealing with a couple of ill family members. My father was diagnosed with metastatic cancer, and my eldest child was dealing with a significant medical issue as well. And, towards the end of 2022 and leading into 2023, when my father needed more care, as did my eldest child, I did have to take some time off, about 6 weeks, to kind of help care for my loved ones and ultimately deal with bereavement. My father will have passed away a year this coming Saturday. And I was not able to find somebody to look after my practice during that time. Another issue that is leading to burnout amongst family doctors is we just simply don't have replacements available when we need them. Similar to substitute teachers, we don't have substitute doctors to fill in when needed. And so at a time when I should have been caring for my family, I was still responsible for my office expenses, those 100 messages a day in my inbox, all the paperwork, etc. So it was toward the end of that leave when I was coming back to work that I decided that I had to make a change. For my own well-being, for the well-being of my family, something had to change. And ultimately, that's what my final decision was, to leave family medicine.
Thank you, Dr. Leahy, for that personal account. I'd like to turn things over to Dr. Dannica Switzer, who works as a rural generalist in Northern Ontario. You left your full-time position with the Wawa Family Health Team at the end of last year. What went into that decision? And from your perspective, what system solutions are needed?
Hi, thank you, Dr. Park. So my name is Dannica Switzer. I'm from Wawa's and I was born and raised here, and I came back to work. I did my medical school in Thunder Bay and residency in Saskatchewan, knowing that I would come back to the north to practice. And I did return in 2017, and I took on a full-time practice in Wawa in 2019, and that continued on until the end of August of 2023. In Wawa, I was doing full scope general practice. So this is office work, seeing my inpatients in the hospital, doing emergency department shifts, which are 24 hours, making home visits, doing palliative care, small procedures, teaching learners, as well as doing the primary care memory clinic. When I started, we were 7 doctors filling the government assigned quota of 6. So we had internal coverage. There were lots of us. The work was a reasonable load. In 2021, we lost 2 colleagues, went down to 4 doctors, now filling the role of 6. And we lost another colleague as well. So we went down to 3, so we have 4 doctors in town. And we maintained that for 2.5 years until we lost a 3rd colleague in June of 2023. And we were facing being only 3 doctors in town. Also last summer, the government assessed how much work we're doing and thought we should be 7 doctors. So you're going to be 3 physicians doing the work for 7. We had multiple rounds of discussion with our Ministry of Health contacts, and they repeatedly refused to provide meaningful long-term support to the vacant practices for the missing doctors, for the 4 physicians who don't exist in our town. And the contract that we work under, which is from 1996 and has not been meaningfully updated since then, I was in elementary school at that time, it simply falls to whichever doctors remain in town to do all the work. And that is an untenable expectation. In addition to all the clinical work, there's also administrative roles and leadership roles that doctors in small towns are fulfilling. So I made the very difficult decision to close my practice, abandoning my patients and my colleagues. And it's not that I'm not working now, I continue to work. I was back in Wawa for 5 weeks of a locum through November and December, and I've been working in other places as well. So I think now my job is being part-time, where I choose when I work and how much, also where I work. If we're going to change things in the north, particularly in small towns when we have a small group of physicians, rural family doctors who are doing everything, we need both immediate measures to retain these practicing rural physicians who have so much experience and play such an integral role. We also need long-term plans. We have decades showing that short-term solutions based on the political cycle are not working. So it's time for much longer-term plans for the north. We cannot recruit our way out of a retention problem.
Thank you, Dr. Switzer, and thank you to all of our panelists for sharing their stories firsthand. We are now going to open up our Q&A session. The OMA's Emily English will moderate this portion of today's briefing. To the media, please put your questions in the Q&A chat. If we don't get to your questions, our media team will follow up with you. You can also email media@oma.org with requests for interviews or information. We will take questions from journalists, and panelists can discuss via, yeah, so I'll turn it over to Emily.
Thank you very much, Dr. Park, and thank you to the panelists for sharing their stories today. And Dr. Park, I want to start with you about what kind of impact does this have with the crisis we're talking about in family medicine today? What kind of impact does that have on a patient level?
I mean, so much so. You know, patients rely on their family physicians for so many things, but the bottom line is they rely on them for their health. You know, and as Dr. Leahy had alluded to, when you get sick, your family physician acts as your navigator, your quarterback through the system. And as frustrating or as challenging as that is the role that family doctors want to provide in terms of supporting their patients. And when that doesn't exist, or when that's not there, patients don't get the care that they need from the beginning of an illness process to the end. That can have patients feeling alone, that can have them feeling that there's no one there to protect them or to walk them through that journey. And that's a very vulnerable time for patients. So it's incredibly impactful. And that's, again, only speaking about the illness journey, not the prevention journey, all the things that go into keeping a person healthy. That is the role and the purview of the family physician. So this cannot be understated how big it is.
Thank you very much. And we have a question from Len Gillis with Sudbury.com. I'll start with Dr. Barber, who's the chair, the OMA's chair of the section on general and family practice. But if others on the panel want to weigh in, the question from Sudbury.com is, what could be done immediately in the short term to turn things around and convince physicians to hang in and continue working? Dr. Barber.
Yeah, well, I think one of the most important things would be some type of stabilization funding. As we mentioned, the inflationary pressures on doctors just can't continue, and they, the doctors need to hear from the government that the government supports them, and so some type of stabilization funding to help with overhead would be really important. And I also think, like I talked before, some kind of signal from the government that they know that this is an issue, they want to help. And what they're doing right now is they want to give family doctors a 0% increase in pay this year. And so when family doctors on the ground hear this from the government, then that just gives them the sense that nothing is going to change, and this is why they're giving up. And I'm sure others have some thoughts on that too.
Thank you. Dr. Switzer, could you weigh in from a northern perspective on what could keep doctors working in the short term?
For sure. So when we're looking at small towns where it's family doctors who are providing all of the medicine in these places, we need immediate locum support for the vacant practices. So small towns like Wawa that have a quota of 7 doctors currently have 3 working. So there's 4 missing doctors, 4 vacant practices. There needs to be full locum support for this. So this would be, sending in 20 doctor days per month per missing doctor, which is how much a regular doctor would work. So 20 doctor days a month for every doctor who is not there, as well as a block of overhead funding. You heard my colleagues talk about the cost of running a business. When you go down to 3 doctors or 2 doctors, however many in your small town, you're still trying to operate a business, and that overhead is now being split into much larger pieces with fewer physicians. Those are 2 things for supporting missing doctors, so that the doctors who remain on the ground have a reasonable workload. A second thing specifically for the North is the continuation of emergency department funding, which is set to expire on March 31st. This is, again, required so that we can keep the emergency departments open, not only on the backs of the local doctors who are still working. We need to be able to attract locums in. We're not going to solve this with locums, but without locum support for the full-time, hardworking rural physicians, they're going to continue to leave. So we need retention measures, not recruitment.
Thank you. And over to Dr. Leahy, could you speak to what could be done immediately in the short term to turn things around and keep physicians working?
Yeah, certainly I would echo the sentiments of Dr. Switzer and Dr. Barber in terms of funding. I think that's probably the number one thing right now in order for doctors to keep their businesses up and running and pay their staff and pay their heating bills and their rent and all the expenses that go into running a business. They need money, they need funding. Without that, people cannot keep their businesses running. So that would be first and foremost. I mean, certainly if we had a centralized referral system, I don't think that would be that difficult to put into place, that would save a lot of time for family doctors in terms of trying to arrange referrals to specialists, certainly. And looking at the volume of information coming in from electronic medical records, especially from hospitals, I mean, there is a way to streamline that information, I'm sure, so that only the essential information is getting to our inboxes. Those are 3 things that could help right away.
Thank you very much. And we have another question now from reporter Marcia Frelick. I'll direct this one to OMA President Dr. Andrew Park. She's asking, Ontario has become the 5th province to make a deal with the government, the federal government last week for more funding. Is that hopeful?
Yeah, so that federal government deal was for $3 billion over 3 years, and while that's hopeful, and certainly the focus being on primary care, is a good thing. We still have a long ways to go in terms of federal funding reaching that 35% mark of total healthcare funding. So at this point, we're still so far behind the mark that while we're hopeful and think that there's a lot of good use that can be done with that money, we're still quite a ways behind in terms of the funding that we need for a stable system. That, again, as my colleagues have been talking about, what makes our system sustainable, we need to get to that point.
Thank you very much. And another question from reporter Elizabeth Payne, who's with the Ottawa Citizen. Is the exodus of family physicians speeding up in Ontario? And are we revising estimates about how many patients could be without a family doctor in the coming years? Dr. Park, could you speak to that?
Yes, is a short answer. So where we saw attachment rates for Ontarians a couple of years ago, that number has gone up, and it will continue to rise for a couple of reasons. Number one is my colleagues have talked about a model of unsustainability that's going to have other family physicians making similar decisions, but also because of our aging and demographics curve, both from a physician workforce standpoint as well as our population, we are heading into a perfect storm. And so it's very important to realize that we have up to 60 to 70% of our workforce that is looking at reducing attachment through comprehensive family medicine because of one reason or another. And that's why we're having this conversation today.
And Dr. Barber, over to you on the growing number of patients who might be left without a family doctor.
Yes, I mean the current number is 2.2 million, and the Ontario College of Family Physicians has worked with researchers that project that will be 4.4 million by 2026. 4.4 million is 1 in 4, so 25% of the population in Ontario without a family doctor. That means no access to our healthcare system, which just is not fair. I would point out that some of the funding that was mentioned, the federal money, I mean, it seems like a big number, but the problem, what I didn't hear was where some of that funding would go to the doctors on the ground. And so, they mentioned hiring 600 or finding or training 600 new family doctors. The reality is that only covers 600,000 patients. So when we're looking at 4.4 million without family doctors, which means 5,000 patients every year are going to lose their family doctor, that's just not enough. And so there has to be different solutions that we're willing to work towards.
Thank you very much. And we have a question from a reporter with the Sioux Star, reporter Kyle Darbison. I'll start with Dr. Park, who's been advocating on this issue in Sault Ste. Marie. And perhaps Dr. Switzer, if you could weigh in afterwards with the northern perspective. Dr. Park, what was your reaction to the group health center in Sault Ste. Marie derostering 10,000 patients? And what are some solutions on recruitment in Northern Ontario?
I mean, my reaction was I was devastated. I mean, the reality is for those 10,000 people to lose a family doctor, as I talked about up front in terms of the importance of family doctors, both to the patient care journey as well as our communities, it's an enormous contribution that family doctors play. And having talked to some of that group, like my colleagues here, Dr. Switzer, Dr. Leahy, these are not decisions that family doctors want to make, or they struggle with immensely that decision because they understand the true patient impact of what this is going to mean. So completely devastated that that's a pathway, and also for the Sioux, that this isn't the first time this has happened, and this is not the last time this will happen. Projecting up to 1/3 of that city will be without a family doctor is going to create an impact on their community in terms of, from a health perspective, that is potentially catastrophic. So that was terrible news to hear all of that at once. In terms of solutions, I do think that it's important that that they look at the model that they have there, and certainly we look at the model province-wide and say, what makes this job unsustainable? Whether it's infrastructure support, whether it's the bridge funding that Dr. Barber had mentioned, whether it's support for centralized referrals, Dr. Leahy has mentioned. It can't be this inefficient and this inefficient and burdensome to practice medicine in this province, and that's what it's become. So you're hearing my colleagues, you're hearing family physicians across the province voting with their feet because this job is unsustainable. And so we need to show real demonstration that we both understand that and that we're making real changes to fix that now.
Thank you. And I think some of the other panelists can weigh in on this question. Dr. Switzer, your reaction to the situation in Sault Ste. Marie and the recruitment and retention challenges there.
Yeah, so it's certainly disappointing, but not that surprising given the landscape of family medicine these days. Adding on to what Dr. Park said, I think a strong point of the group health center and any model, going back to retention, what do family doctors want to practice in? You want to be with the team, you want to have support staff with you, you want to have other providers who can be seeing patients with you to amplify the reach of a single family physician, not replace physicians working together. I think there's probably an appetite for alternative funding models beyond fee-for-service. We know it's very difficult to try to make a business. Look at what BC has done. They have a new longitudinal family physician payment model. And I think the challenge is, whether it's the Sioux, Sudbury, Thunder Bay, or the dozens of small communities in the north, I think it reflects a greater challenge and the fact that we need a long-term strategy for Northern Ontario and Northern Ontario healthcare in particular. We have stopgap measures and Band-Aid solutions. We need a long plan. NOSM is doing work on this through their physician workforce strategy. And the Ontario government has looked at this previously with reports from 2010, 2012, and 2014 that haven't been implemented. The Auditor General's report from December of 2023 highlighted many shortcomings as well. So I think we need to move towards a multi-year, multi-decade strategy for Northern healthcare.
Thank you very much for that answer. And another question, I'll start with Dr. David Barber on this. This comes from Megan Ogilvie, who's a reporter with the Toronto Star. Dr. Barber, what are the top practical ways to reduce administrative burden for family doctors, and who is responsible for reducing that burden?
Yeah, that's a great question. The first piece would be just to reduce the amount coming in, and there are things that can be done in regards to that, and that would be on the government side. Eliminating the requirement for sick notes would be a good start. That did go away during the pandemic, but was brought back. I don't know why. I don't know if that's corporate interests that were a part of that. Nova Scotia does not have that requirement anymore, so get rid of that. I do think some more regulation around insurance companies and the amount of data they require from us. It seems to me that a lot of times what's happening now is that claims by patients are getting rejected right off the bat, and then that comes back to us to justify our recommendations. That would be another piece. On the flip side, the burden of the administration piece that's left, I think that's really spreading it out among the team that I talked about. The reality is there's no margin in this business of family medicine. To hire people to do this is just not on the table. Family doctors can't innovate when they don't have the funding to do that. And which is a bit of a shame, because there is technology now that actually could help us out quite a bit. So, I mean, again, this is, I mean, the government has a huge role to play in reducing the burden.
Thank you. And Dr. Leahy, could you please weigh in on that from your perspective?
Yeah, I would agree with what Dr. Barber has suggested. In addition, I mean, and Dr. Park had alluded to this too in terms of a centralized referral system that would go a long way to reducing some of that burden. Even the forms, I mean, right now, every hospital, every diagnostic imaging center has their own form that needs to be completed for imaging requests. If we just had a one form fits all, just like we do for lab work, there's a one form that we use for requisitions for lab work. If we had the same thing for diagnostic imaging, that would be a huge reduction in time spent trying to find these forms, fill them out, send them, get them back, asking us to fill out the new and improved version of that form. If we just had an Ontario form for imaging that we all use for all centers, that would be a huge win. And similarly, with all the requests for information from employers and insurance companies, again, those forms all look different. They're varying lengths in terms of the amount of pages, the information requested. If there was a simplified and standardized form for insurance and employer forms, that would also be very helpful.
Thank you very much. And Dr. Park, we'd like to ask you about the centralized referral system. We have a few questions in the chat about that. The OMA has been advocating for a centralized referral system. Can you talk to us about why that's so badly needed?
Yeah, so maybe I'll take a step back here and just explain how the referral process works. So you see your family doctor and you need to see a specialist, or as Dr. Leahy's alluded to, you need an imaging referral or a test. So your family doctor then fills out a referral form. That referral form can be any number of specific forms for specific specialists. But you don't know what's on the other side. You don't know their wait times. You don't know exactly whether they're a specialist in certain procedures. And so if you get that wrong, that referral bounces back. Now introducing a delay in maybe days, if not weeks, to your patient's care. So then you go on to the next specialist, trying to again find out that process, because we're really working from almost a yellow pages type system right now. And we have family doctors that are reaching out to their contacts locally, and this is particularly true in centers where either you need a referral or you need someone outside of your city to get that referral. Because if you don't know a person outside of your city, it becomes even more difficult to get that referral placed. This is crazy. And I think it is time that we looked at how a central referral system, like all major companies would have, would help benefit that of physicians navigating the system for their patients. Because right now it's just too inefficient.
Thank you very much. And we have a question now from reporter Tim Kelly. I'll start with Dannica Switzer, Dr. Dannica Switzer on this, and then perhaps Dr. Leahy would also like to weigh in. The question is there another way to handle the volume of paperwork that family doctors get? Are AI tools and technology available to help? And is there another way to reduce the administrative load?
Yes, so this is when you learn I'm actually a dinosaur. I like to get faxes and please mail me a check. So non-technology ways would be literally just having teams. So many of these forms do not require a physician to be filled out. So if we had adequate support staff in the office, they could start the forms, do large portions of the forms, especially social workers or social services workers. If we had pharmacists working with teams, pharmacists can be working on the medication forms. So a lot of this work is being done by physicians, doesn't currently require physicians. This is low tech. It's putting physicians in with a highly functional, integrated, multidisciplinary team. So I would vote to have teammates help with paperwork.
Thank you. And Dr. Leahy, did you have some comments to add?
I mean, yeah, I would certainly echo that. Currently, I'm now working in a hospital setting, and we have a dedicated department that deals with form requests. So that could go a long way. Having a team-based model would certainly reduce a lot of that administrative burden. In terms of the AI question, I have seen AI scribes used in terms of helping docs with charting. Again, that's a financial investment for doctors to undertake at a time when they're already struggling. But as you heard mentioned before, it's not the charting that's necessarily the administrative burden piece. And as far as I'm aware, AI hasn't been used, to my knowledge, to fill out forms, fill out paperwork. If there's a way for that to be implemented, maybe, but I haven't seen that done in practice as of yet.
Thank you very much. And we have a question now from reporter Jacqueline LaBelle, who's with Global News. Dr. Park, I'll direct this one to you. What would you say to anyone concerned with issues in Ontario that this could pave the way to towards pulling back from public healthcare and introducing more privately funded healthcare?
Yeah, I mean, yeah, we share that concern, and I think it's really important that if we're to look at the foundation of our system being primary care and having every Ontarian have a family doctor, then that goes a long way into ensuring that our citizens are healthier overall. Access is something that we have been talking about for our patients to have access to their family doctors, and blocking that or impeding that or creating bottlenecks to that is something that we have no interest in. And I think payment models are another form of that. So, this is very important that everyone has access to a family doctor across this province, and any erosion of that is something that we would not stand for.
Thank you. And over to you, Dr. Barber.
Yeah, thanks. I mean, I don't think that people realize that this is happening already, right? I mean, because I have patients, had a patient recently who needed a specific test, and so they went to Montreal to get it, paid over $2,000 to have that test done, where other patients are waiting months or a year for some of this testing. So it's already here. You've heard about nurse practitioner clinics that are charging $500 to give patients access to the healthcare system. And there are a lot of other examples. I mean, some of what patients are being charged by pharmacies to give injections, that's privatized as well. And so, we are heading in that direction. Like, there's no doubt about it. We're heading towards the American model, and that's the result of the, general underfunding that we're seeing. And it's going to get worse, which just, weakens the system overall. So, again, something really quite sad.
Thank you. And a reminder to journalists, because we are nearing the top of the hour, that you can put questions in the chat. If we don't get to your questions, please reach out to media@oma.org. We will follow up with you. We can also arrange individual interview requests if needed. We have another question now from reporter Ian Adams, who's with simco.com. The question is, are some areas more susceptible to the doctor shortage than others, i.e. urban versus rural? I wonder if the panel could also speak to the issue in the context of municipal physician recruitment programs. It seems as though municipalities are competing against each other for a shrinking pool of family physicians. Dr. Leahy, we'll start with you.
Yeah, I mean, I think all areas are dealing with the physician shortage. Probably the rural areas are feeling the pinch more. Where I live, there's certainly a shortage of family doctors taking on new patients or setting up practice, but we do have a fair number of walk-in clinics that try to fill some of that gap, which I don't believe they have that degree of service in the north. And the municipality I live in, Whitby, there is a collaboration going on right now between one of the large medical clinics here and the town in terms of a financial incentive for new family doctors joining the clinic. It's a small amount, but it's something. I think municipalities are coming up with creative ways, right? Because they feel that if the government of Ontario is not helping to recruit and retain physicians, then it's kind of left to the municipalities themselves. And I mean, that's something that you hear about all the time in all towns and cities across the province, is a lack of access to primary care. So I don't know if that answers the question, but that's my take on it.
Thank you. And Dr. Switzer, could you add your thoughts from as a physician in Northern Ontario?
Yes, so indeed in the north, we don't have many walk-in clinics. That is the emergency department, which is also staffed by the few family physicians who remain in town. So what I see in the north is that there's not a lot of dollars being thrown out by individual towns because there's just a money shortage all around up here. All the communities pretty much offer the same thing. What I do see, so I'm going to spin your question a bit to a different answer, but what I do see is collaboration between recruiters. So if we're trying to keep the emergency department staffed, if there's one site has 2 physicians available at the same time for the same dates, live in touch with their neighboring, which might be even a couple 100 kilometers away, colleagues say, hey, I have a doc, we don't have a need, do you have a need? So kind of sharing the resources. And I wonder about how can this be done if we had a northern healthcare strategy that included workforce planning. Could we have a regional recruiter, so Ontario Northwest versus Ontario Northeast, and they're recruiting for all these communities and trying to find the best fit for an individual physician and their family, and the role that a regional recruiter, regional coordinator could play as well for finding short-term locums. And if we had a healthcare strategy for the north, could this even include salaried locum positions? So you have a pool of locums who are salaried and they're sent to communities to help out where there's need. So I think rather than competing against each other in the north, I think we have a bit more of a collaborative model.
Thank you very much for that question and for that answer. We have another question now from Megan Ogilvie, who's with the Toronto Star. I'll direct this one to OMA President Dr. Andrew Park. You've surely gone to the Ontario government with these concerns. As of February 2024, where do these discussions stand?
Yeah, we've absolutely gone to the government with these concerns, and we have the government's ear. We're having productive conversations, but I think that there's a couple of things here. Number one is to highlight the urgency to which we're having these discussions and say, that this is a responsibility of all government, all parties in government, to ensure that we are creating a system that is sustainable for the future. Because right now, clearly, as you're hearing, that's not the case. So we have had those conversations. We continue to have those conversations, but we need to stress the urgency of how quickly action needs to be taken.
Thank you very much. And a question now from Natalie Van Roy, who's with CTV News Ottawa. Dr. Barber, I'll ask you to chime in on this one. She's asking, a family doctor near Ottawa has made the difficult decision to close his practice. His practice includes 1,500 patients. She says Ottawa is already grappling with access to primary care, and the city is currently short 171 doctors. What needs to be done to ensure that these patients don't fall through the cracks of the healthcare system? Is this scenario becoming increasingly common across the province, particularly in Ottawa?
Mm-hmm. Yeah, that's a great question. So yes, I am aware that Dr. Ramsey Hijazi was the physician who's moving to another job. This is good. This is happening, across Ontario. We've seen it in the Sioux, Kingston in my community last summer. 6 physicians retired and left 7,000 patients without a family doctor. I can't imagine, the harm from that. But those patients, don't have anybody to follow their chronic diseases, to manage medications, and on and on and on. And it doesn't even it doesn't even take into account the screenings, the cancer screenings that are not happening. So we're definitely going to see more of this as we move forward, unless there's something done quickly, like in terms of stabilizing the current system and helping the doctors on the ground. For those patients that lose their family doctor, I mean, certainly, the government could move quickly with some funding to fund some kind of walk-in clinic. In Kingston, Dr. Jane Philpott, our dean, is starting a program called Periwinkle, which is specifically tasked with looking after the unattached patients. So there is some innovative models that could be used to help those patients. I'm just not sure. I'm not hearing anything from the government about doing something on a large scale.
Thank you. And we have a question about team-based care. Perhaps Dr. Park, I'll start with you, and Dr. Barber, if you wanted to also weigh in on team-based care. This one comes from reporter Shannon Kirky, who's with the National Post. So a team model where a doctor is a member of a team, and the doctor doesn't have to worry about administrative or burdensome tasks. So how could a team-based model help the administrative burden? Dr. Park, we'll start with you.
Yeah, I mean, I think of teams as potentiating the ability of each individual to do what they're most capable of doing. And in this case, that's for doctors to be doctors. As you're hearing, doctors spend an inordinate amount of their time just not being doctors. And when there's time being spent not doing the thing that you train to do and want to do and know that your community needs, that's extremely challenging for our colleagues across the province. So creating a team that supports the physician in that role with other allied health, nurses, nurse practitioners, pharmacists, social workers, dietitians, physios, all supporting the patients in wraparound services is a much more effective model of care, where the doctor being all things to all people just isn't what is a realistic expectation of our physicians, which has been the case. So that's how a team can really support both the physician as well as their community of patients.
And Dr. Barber, could you please weigh in on team-based care?
Yeah, certainly team-based care has an important role in fixing the problem now. I mean, the way that I would look at it would be, family doctors, see a number of patients a day. The reality is that some of the issues that come in could be managed by other allied healthcare people. For instance, if there was funding to hire a physiotherapist, that physiotherapist could assess all the patients that come in, with joint pains or back pain, and in collaboration with a family doctor, help that patient. And what that's about is opening up spots, right? And so if you can open up, if you can have the family doctor see other patients, that means they can take on more patients. And this is what we're getting at, is that the doctors, if the funding is there, could roster more patients. And if every family doctor in Ontario rostered 200 and I think 40 new patients, then our problem goes away. So there's a ways to get there, but that certainly is part of the solution.
Thank you. And Dr. Leahy, could you weigh in on team-based care?
Yes, certainly. And I mean, that was what I was kind of hoping for all along in family medicine, as one of the things that would help me to stay in family medicine was the promise of team-based care, which still has yet to be realized on a large scale in Ontario. But I currently work in a team-based model now in oncology. I mean, I am in a space where I have pharmacists that I work closely with, a social worker, dietitian, drug access facilitator, a department that deals with forms, clerical support. I mean, and it works extremely well, and all for the better of the patients. The patients have a much, much better experience when everybody is working together and for them. And that certainly could be done in family medicine with the right funding and the right supports. And I hope that is coming soon.
Thank you. And Dr. Switzer, your thoughts on team-based care?
So I feel really lucky to have worked in a small town in the north and locuming in small towns in the north, because we have teams. So most of these small towns have a group of physicians who are aligned with the family health team. We have access to nurses, nurse practitioners, dietitians, social workers, counselors, pharmacists in some teams. And it's great. When I was working full time, all my diabetes patients were seen by the diabetes educators. Nurses were seeing patients for hypertension. Nurses were seeing patients for well baby checks. And it worked well because it amplified the number of patients that could be under the umbrella supervision of a physician. But that said, even though I was essentially on a salary model and working in a team, the workload was completely unsustainable when the model left it so that I was having to do the work of 1.5, 1 2/3, 1 3/4 of a physician, and on the same salary for one. I don't want a higher salary. I don't want to be paid twice as much. I just want to do the work of one doctor, not two. And that's the challenge with small towns when you go down a model that doesn't support the vacant practices adequately.
Thank you. And I just want to take the opportunity to again thank the panelists who shared personal stories today. We appreciate your advocacy work and bringing attention to this issue. And we are just past the top of the hour, so nearing the end of our time and actually gone a little bit over, but I wanted to get a final thought from each of the panelists today on what you would like the public to know, or the takeaway message on family medicine today. And Dr. Barber, perhaps we'll start with you.
Well, I mean, I think the public needs to know that they're probably at risk of losing their family doctor. I mean, if I was a patient, I'd be asking, my family doctor, one, how they're doing, but also, what are their retirement plans, or where are they planning? Are they thinking of leaving practice? Because, if we're in 2026, if we're moving to 1 in 4, that's a scary proposition, to not have access to that, to the healthcare system. So, I just think it's important for the public to be aware of that and to contact, their elected officials to implore them to do something quickly about this issue.
Thank you. And Dr. Leahy, a final thought from you on family medicine and what the public needs to know.
Yeah, sure. I mean, I fundamentally believe that primary care is the bedrock of our healthcare system. There's lots of data out there that will demonstrate that investments upfront in primary care will save money, save healthcare dollars down the line. Right now, the primary care system in Ontario is beyond crisis levels. And I think the public needs to be aware of that. We need immediate and long-term solutions that go beyond the next election cycle, like Dr. Switzer had alluded to, things that we're looking decades down the line. If we don't get this right, there's going to be, I think the health of our province depends on getting this right and getting it right now.
Thank you very much. And Dr. Switzer, a final thought from you on what the public needs to know about family medicine right now.
The public needs to know that family doctors care for them and care about them, but we cannot continue to prioritize patients' health over our own physical and mental well-being. And to make family practice sustainable, we need immediate help from the government.
Thank you. And thank you to all the journalists who attended today and for your questions. Please follow up with me, media@oma.org, for any extra interview requests or information that you may need. And thank you for the questions in the chat today. And thanks again to our panelists. I'm going to turn it over to OMA President Dr. Andrew Park, who has closing remarks for us today.
Yeah, and I'll just reiterate my thanks both to our panelists as well as the media for your thoughtful questions. Just some housekeeping. We will have a recording of the session available later this afternoon. Ontario's doctors want what's best for their patients. Lack of access to a family doctor can negatively impact health outcomes. We absolutely need to build a more sustainable system that allows us to retain and recruit physicians to want to work in family medicine. In the OMA's Prescription for Ontario Doctor Solution for Immediate Action, we have called for solutions that tackle the crisis in primary care. We hope to work with the government to ensure that there's a future for family medicine in Ontario. Everyone in Ontario deserves access to a family doctor. 2.3 million people in Ontario are currently without it. We hope bringing attention to this issue today makes a difference. Thank you and have a good day.